Welcome everyone. This is Sina Saygılı from Turkey. Our show will be today with Dr. Luis Cuadrado from Spain. We mainly made a couple streamings with great professionals from all around the world, like Christian Kochman, Alessandro De Vigus, Galip Gürel, and now today we will have another professional, which is the expert, one of the experts in the dental field with the implantology as well, and he implemented the digital technologies in his daily life excellently, let's say. And we will just ask questions to him, and we will try to gain his experience in a short notice. I will just briefly would like to explain. Dr. Cuadrado is one of the keynote speakers of one of the huge companies in the world, which is the 3Shape, Ivoclar, and Straumann, as the ones that I know actually. And Dr. Cuadrado is really kindly accepted my invitation, and he's here today. I would like to welcome him. Welcome, Dr. Cuadrado.
Thank you so much, Dr. Sahili. Thank you so much. It's a pleasure to be with you this afternoon, sharing our our thoughts regarding implant dentistry. So thank you, and I'm very happy to be with you. By the way, I'm in love with Turkey. So it's an amazing country, and I've been there a lot of times, and I hope to be there more times because it's amazing. Thank you. Thank you for inviting me.
We will be pleased to see you. Like you were in Antalya lastly in ITI Congress, and hopefully you will be back after the COVID process. Probably we will see you more and more in Turkey. Hopefully.
Yeah, I hope so. Excellent.
Okay.
Excellent. So thank you for inviting me again.
Yes, thank you for accepting my invitation, because it's out of the work times. It's the evening time actually, so it's a pleasure for me to see you here and to have a conversation with you and have my question already ready for you. But before we start, I'm not really the person that do the normal introduction for my guests. So, with your kind words, please explain who is Luis Cuadrado.
Okay, thank you. I'm a dentist, but I'm also a plastic surgeon. I didn't practice regarding plastic surgeon about plastic surgery from the last 15 years, but I have a deep surgical learning, thanks to plastic surgery. So my main work has been for a long time, from more than 30 years, regarding implant dentistry and reconstructive surgery, and more or less maxillofacial surgery, I will say, And I practice in my clinic. Here is I2 Implantology, I2 Implantology, which is a clinic here in Madrid. We are located on the downtown. This is a clinic center and also a learning center with a huge program regarding not only implant dentistry, but also regular dentistry, prosthetics, aesthetics, and everything. And we are mainly focused with the digital approach regarding all the fields regarding implant dentistry in our clinic, from ortho to implant to different approaches. And I work in a team approach. We have a small digital lab here. It means that that's very important according to what we are going to talk, because we have 2 dental technicians here, and they help us on a daily basis in our cases. Just coming from the pre-op study to the final delivery of the prosthesis. Also, we work with renowned dental technicians worldwide, with Arturo Godoy in Mexico, with a lot of them, and trying to provide our patients, that's our aim, to provide a simple and predictable treatment thanks to the full digital workflow. So it applies from single unit to bridges to full arch. And we are really happy with this new. For me, this is a new implantology. I always say the same. I think in my career, I've seen two main topics changing dentistry, changing implant dentistry. One was osseointegration, of course, and the second one is digital. So the digital approach is mandatory if we want to give our patients the best treatment dentistry can provide today. So this is my profile. The most important thing I will say is this is a team approach. It's very important to work as a team with the dental technician, with the prosto, from the surgical point, everything all together with the same point of view, you know. So I think that is very important.
Perfect. With as you mentioned, like you have 30 years of experience already. So you saw the two breaking points of dentistry. But the new era implantology, the new era in the implantology is digital. Like everyone is accepting this. But what changed in the last decade that these digital applications are so needed, are so helping us in the clinical workflow? Because 10 years before, you were doing probably the same quality dentistry, but what changed with the digital approach?
I can say that I'm a better implant surgeon thanks to digital. That's very important because always I'm placing my implants. I'm thinking more than ever on my prosthesis, and I will say more than ever not only on the prosthesis, but on the material that prosthesis is going to be made of. You know, so it makes you to see things in the different way. And why? Because you and me, we all know that this is not only digital or only surgical or only prosthetics. It's you know, it's like a total treatment, you know. So everything has to be done in the correct way. So we think different. For example, I would say that one of the most important points is to use immediacy, immediate loading, same-day dentistry in most of our cases. And thanks to all the developments regarding implant designs, implant surfaces, the way we perform surgery, the way we take we know we can load that implant thanks to the Ostel, to the ISQ level, and then thanks to the digital, everything is much more easier. But you have to think different. That's the question. There is a point when you need to realize, one needs to realize that to provide, for example, a single crown in 1 hour is possible thanks to digital. Extract the teeth, place the implant, scan, produce the crown, and place even on a final material. That's very important, not only on PMMA. So it means for the patient, service. It means quality of treatment, just one visit, same day. In fact, we are providing our patients what we are looking for as a treatment when we are the patient, you know. So I think that all now we are reaching a point that everything is amazing regarding this, because we can provide the treatment we ever want to give this treatment to our patients. So it's very different from even, I would say, 10 years ago, 15 years ago, and I think it's only a kind of happiness, you know, for all of us, for the patient and for the dentist and the dental technician, of course.
So, like the point of view is completely changed. So let's say when you think about using all the technologies and utilize it during your workflow, then it's somehow making you more comfortable, let's say.
Yeah, more comfortable, more precise, everything. For example, if you are using the intraoral scanner, most of the times you have to be minimal invasive with your surgery. So it makes you a more careful dentist, you know, surgeon. So you treat your tissues, the patient's tissues, with better care, you know, more in the appropriate way, I will say, you know. So it makes that even your post-op is much better for the patient. And your scanning is not only your scanning, it's also the post-op period, everything is much more easier. So I will say that it's not only the technology, because I want to remark again that you have to follow a complete workflow, starting from the diagnostic period for the planning to the final prosthesis. And then in the middle, you have the way you do your surgery, you perform your surgery, the implant you have select to make your immediate loading. If you are able to place to make immediate loading to load that implant thanks to the hostel. If you need to scan to use the intraoral scanner, so you have to fulfill some kind of points, of special points that you need to master. For example, you need to control the mobility of the tissue, because especially in the lower, if you are scanning a patient with mobile tissue, it's going to be almost impossible. So there are a lot of facts that you have to control, and they are related to technology, but I will say that technology is only a point that helps you to give the treatment. You know what I mean? It's the way I see, you know. And of course, you need to control everything regarding the dental lab. I'm talking, for example, about the libraries, about the scan bodies, about the software, the design software, about the production, the milling machines, the printing. Everything has to be mastered. And once you have all your package mastered, you are the more happy dentist in the world. You know, that's very important to master, to have the package, you know, I will say.
Every circle or all the machine parts has to work completely perfect to achieve a really good success point, to reach a real goal.
Because imagine there are some I would say stupid points, you know, like your milling machine is not calibrated in the right way, so you are not going to get a temporary prosthesis, a correct temporary prosthesis. So you have to be careful with all those steps, and that's very easy, because once you do it for once, then you have it forever. You know, you need not. My advice would be not to change from one implant system to another system. Once you are happy with your implant system, with your abutments, with your scan bodies, your dental technician is familiar with the way they have to design and to produce, then it's like a machine, you know, it's always the same.
So as you say, like, this is the teamwork, and the main part here comes from the technician. Actually, the design and the production is completely really important for the passive fit, for the stands, for the guides, to achieve a better solution. So how you rely on technicians' designs, or how you just control those steps from your lab side, so you can be sure that everything is okay?
In my case, yes.
Yeah, in your case.
Fully confident, 100%. 100%, because
so how you reach that point for the 100% confidence?
That's the best question. Say, I don't know when we reach that level, but the fact is that we did it. So of course it was not easy, not because of the dental technician, but because we have to look for and find, and that is very important point, what we want, you know. So 5 years ago, 6 years ago, 7 years ago, it was really difficult, because nothing was designed for the intraoral scanner. I'm talking, for example, about the scan base, the scan flags, even the libraries or the D-bases. And now, if you think twice, now all the companies, not only the implant companies, I'm talking about also, for example, about Ivoclar Vivadent, which is leading the market, and the implant companies, of course, and second companies making abutments, for example, or scan bodies. They are all focused on the digital market, I will say, and not only on the lab side, but also on the clinical side, making everything, all the portfolio is focused to the intraoral scanner. For example, formerly you can choose only between too long, too high scan bodies, or a shorter one. and sometimes it becomes covered by the mucosa, you know, or you can not scan because they were too long. Now the companies are looking for the good advice to design the products according to the things we need to be used with the intraoral scanner and the libraries and everything. So I don't know when we reach that point. I cannot remember right now, but maybe 5 years is a short time. Maybe it was. I have to say, for example, and I think it's very important that we bought our first Trios intraoral scanner in 2012. So it's only 8 years of experience. That's a very short time in terms of dentistry, you know, only 8 years working with the intraoral scanner. I will say that from the very beginning, we try to apply our intraoral scanner to all the fields of dentistry. For example, 3Shape told us that with that scanner, with the first one, with the first Trios, we can only make single crowns or small bridges, you know, and from the very beginning, we pushed the system to the limit, and we were able, we did full arch also. Of course, it was very tough, very difficult, but we did it. So it means that technology has evolved, and now, for example, we have 2 Trios 3 in the clinic and 1 Trios 4, and we have no problem with regarding the intraoral scanning with our patients. And of course, we are not using other systems for taking the digital impression, I will say, like the PIC system or stereolithography, you know. Yeah. We only use the Trios. And I think it's, I don't want the phrase I'm going to say you, that our audience could think this is a commercial, you know. But I think that Trios is the only one in the game, you know. We tried a lot of the intraoral scanners, and the question is that with Trios you can do everything with no problem. If someone tells you or told how to scan, how to do things in the correct way, but it is not difficult, you know. So I think that's a very important point, you know? And that's all.
Yeah. Okay. The thing is that, to summarize everything, like failures happens, but when you start to make a common language with your technician, with your prosthodontist, and everyone, then the confidence comes. I think the thing that I understand from your sentences is this: that failures happens, but just if you stick on the plan and find the common language, then everything will be solved. But one of the other questions that I want to ask, actually, but you already answered somehow, that any intraoral scanner or implant company is ready for the full edentulous digital treatments, let's say.
Yeah, again, this is not commercial, and I can say, I can only give an advice based on my personal experience. If you are looking for an intraoral scanner to perform all kind of treatments, especially the full arch, in my experience, it's the Trios from 3Shape. Trios 3, Trios 4, you know. I tried another companies, you know, intraoral scanners, and I was not able to make the full arch so simple that I did it with Trios. But the question is that I have friends, of course, dentists, that they are capable to make full arch with another intraoral scanner, you know. So I will say that at least not so simple, so easy that with Trios. Trios is amazing, believe me, it's amazing. I recommend all of you to try it.
Perfect.
But that's a personal advice, because we are a clinic, you know. I can take, it's the same as you. I'm only talk of my personal experience. I didn't work, I do not work in the university. I didn't have a clear, you know, academic way to compare, only from the clinical reality. I think that's very important to base on the clinical day-to-day basis, you know. But in my experience, is the only one. trios.
Okay.
In my experience.
Yeah, I mean, like, this is why I'm just having guests like you to share their experience, because it's a years of experience, which is not. It is also comparable with the scientific papers and the materials that we see on the studies, that it says you can scan the full arch, you can scan the full arch, but still daily life is different. So there is the workflow. If it's happening correctly, then it's okay. I mean, this is what you're saying, so that's why it's really important for everyone to listen, I think, with your experience. But in this workflow, I think you found a missing point. That's why you created this I2 device, as far as I understand.
The question is that, and it came from your question. No? The question is that I always say that we need to think different. When we are dealing with the intraoral scanner, we know that we need a lot of geometrical structures in the mouth. I mean, teeth or scan bodies placed in the mouth, not too far from each other, you know, to get an accurate file from the intraoral scanner. In fact, to make the intraoral scanner easy. So it's not only a question of the intraoral scanner. The question is that we need to provide the scanner with workflows that the scanner can translate into a valid digital file. So if we are focusing only on full arch, we need to think different. For example, we have different situations regarding the full arch. We have, the first one will be the patient with a complete denture, or even without a complete denture, with no denture, no teeth in mouth. But also we have the failing dentition patients, the patient with a hopeless dentition, and you need to extract the teeth of the patient. Or a patient which is partially dentulous, and he or she has some teeth in mouth. Formerly, regarding this last case of patients, this last category of patient, the patient with some teeth in mouth, or with all his teeth in mouth failing, you need to extract them. Formerly, 10 years ago, in the surgery, I remove all the teeth, place my implants, and then take a conventional impression with silicone, and then I have my impression. Now, thanks to the digital, we need to do things slightly different. We know, for example, that if I imagine the patient has 6 teeth in mouth, 2 canines, 2 premolars, that's all, you know. And I will not remove all the teeth. I preserve some teeth, for example, the 2 canines. And thanks to that, I place 6 implants, and then I have 6 implants and 2 canines. So I have more geometrical structures in mouth to be scanned, and so I get a perfect digital file. So the question is that what we have done here in our clinic is to master the treatment of the full edentulous patients. And we developed different protocols. We call it the I2 Arch. I think we need to change the name because there is one company in Netherlands with the same name, but at least until now, we call it the I2 Arch. So we will, but the I2 Arch comprise all the workflows we use to treat the edentulous patient. So I think I send you,
yes.
Maybe you can show the different.
I just opened it, you can just talk on it.
Okay, so the I2 Arch, it's a complete array of different workflows that apply to different situations of the patient. It doesn't matter if you are placing your implants guided or not guided, because guided surgery is only the way you are placing your implants. Mm-hmm. The question is how to provide the temporary prosthesis and then how to reach the final one. So the I2 Arch has 4 different workflows. One is the conventional, then we have the advanced, then we have the I2 device, and we have the I2 device 2.0. I can say you only a few regarding the I2 device, because the company that is developing with me didn't allow me to talk a lot about it. But I will say you that the I2 device is only a device, surgical device, that you can place in mouth and you can remove from the mouth when you are scanning your patient to copy files between the pre-op file and the final file. That's the I2 1.0. The I2 2.0 remains in mouth, and you can copy all the files from the initial surgery or for the planning to the final prosthesis. So what I'm trying to say is that I need in the mouth reference. Those reference could be the I2 device, or could be teeth, or could be old implants or crowns or everything that the dental technician will mix in the design software to make things simple. I will explain you the most simple situation coming to the patient. Imagine a patient only with 2 teeth, okay? I have my patient with 2 canines in the upper and in a removable prosthesis. That's okay?
Yeah.
I'm going to place implants. So what I will do in the first step will be to take a study model scan. Study model scan is lower, upper, and occlusion. Okay? I have to make sure that I take my canines, the canines of the patient, on my occlusion scan. And I have my initial file, study model scan. Okay? Then I go to my surgery, I place my implants, 6 implants, but I preserve my canines. I leave my canines, the canines of the patient, in place. And then I just scan the upper with the scan bodies and the 2 canines. And now my dental technician has 2 different files, the study model scan and the file with the 6 scan bodies and the 2 canines. Those 2 files has in common the canines. So based on those canines, the dental technician can merge both files and design the temporary based on the pre-op situation of the patient. The I2 device is something similar to the 2 canines that I can place and remove to my election to make things in the same way. For example, when your patient comes with a complete denture, I can scan the complete denture, but when I remove the complete denture, I have no reference to mix both files. So I need to place the I2 device. Based on that, you can treat all the spectrum of patients with full arch, from failing dentition to only partial edentulous to fully edentulous, even with no complete denture, and you can choose if you place your implants guided or not guided. This is very important because, for example, if I can speak only a little bit more.
Yeah, sure. I'm just listening very carefully.
For example, regarding guided surgery, I'm in love with guided surgery, especially with Implant Studio, which is, for me, is the best software. It could be better, of course, but it's very good. Okay, and it means that it is difficult to say, but I will say that 85% of the cases we make our guided planning, design the guide, but we also design and produce the temporary with the T-bases glued to the temporary. So before starting the surgery, we have our guide and we have the temporary prosthesis ready to be placed. We have no indirect realignment. So the question is that if you feel all the steps from the planning to the surgery with the correct way, in the 85% of the cases, I will be able to place, just remove the guide and place and screw my. That's amazing regarding guided surgery. But there are a 50%, 20% of the cases where that's not possible. And then you need to realign your prosthesis or change your T-base or, better than me, all that stuff. Or Or I can decide just to place two scan bodies, for example, for a bridge, scan, wait for my lab for 20 minutes of design and 1 hour, for example, for milling or printing, and then I have my temporary bridge ready, you know. So what I'm trying to say is that following all the DI to arch protocols, it doesn't matter if you come from guided or not guided, allow you to get better results and to avoid wasting time making a full guided planning with the temporary prosthesis. So, for example, what are we doing on our daily basis? We use guided surgery with Implant Studio in the, I will say, 35% of the cases. Most of them should be tough cases where we need to look for, you know, where to place my implants and everything to make it parallel. Or, but usually, I would say the last 2 years, we didn't make the temporary prosthesis before of the surgery. We just place our scan bodies, scan, and produce the prosthesis. That's much better for me because for me, I want to be honest. I want to be completely honest with you, you know. And for example, planning with guided surgery a full arch case takes at least 4 to 5 hours to me. Probably others could be shorter, you know, and less time. But if you want to be accurate, you need to come to the clinic a Saturday or Sunday morning and stay 4 hours making the perfect fitting, the perfect best fit. You know, you have to be perfect. And if I skip that step, not the step, the guided planning, but the temporary prosthesis, everything is much better for me because the patient, I place my implants, scan, the patient waits for 2 hours, and 2 hours later, she has the full arch, you know. So coming to the initial question, the eye-to device is only a part of our protocols, you know, and because there are a lot of situations. For example, we didn't talk about the secondary surgery with the failing implant patients, you know. So there are a lot of things, and sometimes you need to use even we use different. For example, sometimes we use the standard technique, and also we use the I2 device or the advanced technique and use the I2 2.0. It depends on the case. But the question is that when you master all those workflows, your full arch is so simple with trios, so easy with your implant system, amazing. Sorry.
That's okay.
It was a long time talking.
Yeah, it's okay. We are just happy to listen to you. One of the questions that actually pops up not right now, that as you said, if you plan strictly very well the surgery and the implants, you can, if you rely on the steps very carefully, you can have the temporary also ready before the surgery. The thing is that how much you rely on those accuracy, because if we make a misfit and don't feel it when we place this full bridge, let's say, we can have the problem that failing the implants. So how you decide on this to use this temporary or not?
If I understood you, your question is how can I be sure that the passive fit is correct and everything regarding that? With the guided, you mean?
I mean, you did the guided and made the temporary before the surgery, and you feel like maybe there is some not passive fit, but it's between. So how you make this decision about it, to make a new one or use this one?
That's a very good question, Sina. A very good question. I think first of all, we need to remember to all of our audience, if there is somebody novice to implant surgery, that guided surgery is a special surgery to be performed by a very experienced surgeon, because you need to be to feel what you are doing. It's more than ever to feel. You are working more of the times flapless, so you need to know if you are inside the bone or outside the bone. That's a very important point. So the question is, and you have to be prepared to finish your guided surgery, open a flap, and finish your surgery. So that's very important. The question is that it's a very complicated question because we need to start talking about the implant system you are using to perform your guided surgery. And there is a big difference for one to another regarding the material, the hardware, and also the everything. So you need to master to get a perfect learning regarding your the implant system you are using, and you have to be sure that when you just finish placing your implants are in the same position you did it virtually. That's very important. That's very important. So, for example, very simple question. Sometimes we plan our surgery in the guided surgery software, and we place virtually our implant, and it happens that your CT has a lower resolution than the ideal resolution to be sure that what you are looking in your computer screen is the real bone on the patient. And sometimes your implants becomes deeper because it has been placed in the same position that you have placed on your surgery, you know. But sometimes it comes deeper because there is some bone on the top of your implant, and that when you are coming with your temporary prosthesis is not coming in the right way. So you need to master all those things. Also, it is different if you go with your T-base direct to your implant connection, or if you are using a multi-unit abutment, even an angled abutment. Regarding Implant Studio, you are obliged to work to implant level because you cannot place in Implant Studio or dental system, at least until now. They will change that approach. You cannot place your multi-unit abutment. So how can you be sure? Of course, once you have placed your implants, you have removed all the soft tissue around your implant head. You are sure, thanks to the refined drill, that there is no bone between your implant and your T-base, and you just place your temporary, and if everything is correct, it should place it nicely and get a passive fit. We always make, if everything is correct, and I'm really happy with the situation, that's 85% of the cases. I think it's a very high number, but also I'm telling you that we are doing that only in the 30% of our cases. So that's a very not so high number, you know. Yeah. So once you have everything ready, of course we take a pano X-ray and always a CT scan to be sure that the T-base is in the position. For example, if you are talking of Straumann implants with bone level connection, the CrossFit connection, you need to use aftermarket, not the Straumann regular T-bases, because we all know that those T-bases are too long to get a perfect fit between implants. Okay, so even if you have performed your surgery perfect, the prosthesis, if your implant has more than 12 degrees, the prosthesis is not going to enter. Of course, you can avoid that doing your surgery, planning with co-diagnostics, and placing your screw retain abutment and get everything parallel, you know. But also, you can use aftermarket abutment, or simply not to go to the guided prosthesis approach, place your screw retain abutment, scan regularly, and produce it. So there are a lot of things you have to master coming from your expertise as a surgeon, and then how to perform your surgery, how to be sure your implants are in the correct way. It's very important because one of the flaws of guided surgery is that I want to place my implants guided, but the most important thing is that I want to load those implants. So I need that make an under drilling, or you know, it's a very tough situation. So you need to be an expert surgeon to make guided surgery within medial loading. Otherwise, you are going to be very frustrated. I will not recommend to start with a big case. The big case for me is a single unit also. That's a very important point, because single unit, I think, is the most demanding case, especially in this full digital workflow, because it's very simple. No? You get your guide, place your implants, and you have your crown ready, place it, but your implant connection has to be in the same situation, so it's not so easy. But of course, not to go for a full arch case from the very beginning.
Just to contribute from myself, that when we do the guided surgery and the immediate loading in the same time, I made the temporaries, but it's like combining your both protocols, that I just make the combining of the T bases inside the mouth, like the old way. With the temporaries, which is like I have the temporaries already, and just do that and then make a trimming and then make it ready. I think I feel much more safer in this way, but of course it's easier to do if we have it.
No, of course. All of us, we need to be confident what we are doing on a daily basis, So it's perfect, But the question is that I think digital gives you something more, something more for you than your dental technician. For me, digital is happiness. More than everybody is talking about digital. The problem is not because everybody is talking, oh, you can scan and with an intraoral scanner full arch. That's a bullshit. You don't need. Nobody is talking about the silicone, on full arches. What I'm trying to say is that the important is the whole treatment, not only to take with the intraoral scanner the full arch. Of course, it's important, but it's not the only thing. As you have told us right now, you need to, for example, you can do that approach and then finish your case digital, because one important thing is that we have a lab here in the clinic. That's very important. Yeah. We have a dental technician, very expert with that. So for us, it's very easy to provide that kind of treatment. But some colleagues can find in a village far from the dental lab, and they cannot. So I think each of us, we need to be confident with the treatment we provide to our patients, keeping in mind that digital is much easier than any other kind of treatment. I can guarantee.
I completely agree on it. There is one question I would like to ask you this, because I think it's important. Do you prefer the scan bodies from the implant companies, the original ones, or there are some scan bodies made from the intraoral scanner companies like 3Shapes? They have the scan body sets which is designed for Straumann, let's say. Do you use these ones or the implant companies ones? Do you feel any difference, let's say?
Yeah. Thank you, because that's also a very good question. The question is that I will ask your question from the final. Okay, I want to provide my patient with a temporary or final prosthesis, for example, with this T-base. Okay?
Yeah.
The T-base from Straumann or from Nobel Biocare or for anyone, and I want it to be done in my lab. So you need to select your scan body, thinking on the prosthesis you want to provide to your patient and the workflow. For example, if I'm using the Straumann original scan bodies on screw retained abutment, I have to be sure that my lab has the libraries to produce my temporary prosthesis in-house. Otherwise, I need to send that file to the production center. That's very correct, but it takes 4 or 5 days to receive your temp. If you want to provide same-day dentistry, you need to select your scan bodies based not on based on the way you want to provide in the material you want to provide the final or the temporary prosthesis. That's very important. So you can, for example, if you are using the 3Shape scan bodies on Straumann implants, you need to use the ELOS components, that's a Danish company, to provide with those T-bases. if you are using the original scan bodies from Straumann, you need to use the original components for Straumann. So it depends if your lab has the libraries open to be milled in-house, or you need to send it to a
third company
production center.
Yeah.
So it's very different. I will always recommend use original components on your implants, of course, because I think that the fitting and everything is much better. But I can tell you that we have different scan bodies from different companies, different devices, and we try to accommodate that the scanning process and the scan body to the treatment we want to provide. Okay, and there are a lot of, as you know better than me, there are a lot of mixtures right there between different companies to use one another from another. You know? It's very important to select the scan body.
Okay, perfect. Thank you. So one of the other questions about the full edentulous cases that with the intraoral scanning, of course, the accurate bite scan and vertical dimension registration is often questioned by everyone. Like how you decided, how well the decision is correct. So what do you think about it? And with digital way, what you found out that to go out?
I fully understand that.
Yeah.
Let's talk again about the eye to art. Okay, I told you that we have different workflows. Each of those workflows means the way we have to scan, the way we have to design, and the way we take the occlusal, the vertical dimension, the occlusal, and even the aesthetic information. Because let's go to the case I talked to you before, the patient with 2 canines and a removable prosthesis in the upper. If I scan that patient, I have my vertical dimension, I have my occlusion, and I have my aesthetics. I have everything. Yeah. So the question is that how to transmit that pre-op situation to the post-op situation. I preserve my canines. The lab is maintaining the the vertical dimension and everything on the temp, because with the temp, he's copying the pre-op situation. Let's go to the patient with the complete denture, or with wax up, or with teeth in wax. I don't have the reference, the complete edentulous patient, but I place my I2 device. So once I have my I2 device, and I have in one file, I can copy in different files. So I always keep my vertical dimension and my occlusion I want to improve, I need to modify, but the lab has all the information in a very simple way. That's the most important thing, to be simple, to be accurate, and to be something that could be done by any dentist. That's the eye to art and the eye to device. Because we have mastered all those based on a lot of patients. In fact, I think that in October, Quintessence will be publishing a book with all those stuff, you know, regarding also single units, bridges, and everything. The way we are working. It's a book that will be showing the way we work on a daily basis in the clinic. But the question is that taking the vertical dimension, taking the interact relationship, don't think on that. We have it. Okay. We have it because we need to think and to perform things in different way, you know. And one more question. When I was writing this book, I was thinking and writing about medial loading, implant surfaces, you know, macro structures, the occlusion, the distance between the implants, the cantilever, everything, you know, all that stuff that you know, no? And I realized that all those are small pieces of a big cake, you know?
Yeah.
So with digital, all those pieces comes together and give us the big cake, you know? So because everything is interrelated. So the question is that we need to treat our cases in a different way, to think different. The message will be, we cannot try to translate the analog dentistry into digital dentistry. We need to think different. the only way. Because thinking different, it's always easier. And I will be my advice. Think different, and you will find the solution.
Okay, perfect. Final question, actually not final question, but for talking about the digital dentistry and the implantology, you always tell that after the immediate loading, you do the PMMAs for with milling or printed. So the question pops up here, that one of the most feedbacks that I received after the ITA Congress actually about your lecture, that he is doing with the PMMA the immediate loading, but it's not really like how you say it, like metal. Yeah, strict.
Like, I understand what you're trying to say.
Yeah.
Okay, they think you can bend your prosthesis.
Yeah. What do you like?
The prosthesis can flex.
Yes. And it shouldn't be flexible, let's say. Yeah. But I would like to receive your. Yeah.
No. I fully understand, because it's always the same. Everybody is trying to find the. Oh no, everything is correct because is that PMMA is flexible, so he can flex, like, you know. Oh, in fact, we know that's not true, because when you are screwing a temporary prosthesis, a PMMA, a teleocat, you perfectly know if that's passive or not. You know, that's one of the things, one of the questions, because in all my lectures I present video, because that's the only way to the people to show the reality and the benefits of the treatment. The question is that, of course, PMMA could bend. If you are forcing, you can do it. But the question is that that's not true. We are achieving a passive fit. And I can tell you that from, I would say, I think we became crazy this last 9 months, the last 9 months.
Yeah.
But the question is that what we are doing right now is I place my implants, scan, and place the temporary prosthesis with teleocat same day, okay? So imagine everything is correct, the passive fit is perfect, you have your perfect file with your implants, that's okay, and the aesthetic of the patient and the function is perfect, okay? You know what we are doing right now? We are just making the final prosthesis without the scanning, with the same initial file. So we have a lot of cases. For those thinking that PMMA could bend, final prosthesis in full monolithic zirconia, exactly in the new, which is an amazing product, the new from Ivocarby, but then the new IMAX Circat Prime. With the same file, we make the temporary, we just mill that in prime and just remove the temporary and place the final file with an amazing accuracy. You know why? Because on the first scan, we scan with, imagine, 2 teeth and 1 molar. So I get a nicer file, you know? Yeah. And to be sure that our soft tissue is correct, we just remove the temporary prosthesis and scan, but only the soft tissue with the multi-unit abutments, without the scan bodies. And our dental technician is able to match the initial file, the file from the day 0 of surgery, and the final file 4 months later, and take the soft tissue from that file to make the final design. But with only one. Can you imagine that? I'm just, that's amazing, because you just have to scan your patient once, the day of surgery, and you forget about everything. Just scan it, and that's perfect. So it means that the initial file was amazing. And so that would be the good point to show those dentists thinking that the PMMA could bend a lot, to show that the initial file was correct.
Yeah, passive fit is the key here, I think.
Yeah. You realize when you are screwing, we all know what we are talking about, no? And I will not be Luis Cuadrado, you know, if I could make that kind of bullshit to my colleagues. You know, I'm very honest because I have no reason to cheat people for nothing. I just want the people to the dentists and my dental technicians to enjoy this kind of treatment, because it's very possible. If I can do it, everybody can do it. No question about that.
What I experienced with the PMMA, the only problem that I feel, not about the implants, but with the bruxist patients, one of them just broke the PMMA in the middle of the implants connection. So
you mean our experience? No, yeah. You mean our experience with on the long term with the temporary prosthesis?
Yeah, with the temporary prosthesis, the bruxist patients who does the bruxism like really heavily may break the PMMA. This is the only problem I see actually on those.
Yeah,
things.
I agree with that. With TeleoCAD, we have very few problems. For example, we are you and we are only you and me. We are alone, and I can say you that today. We scan a patient. It was a 22, only single tooth. The patient, she didn't come for 3 years. 3 years with immediate loading, with the temporary prosthesis, just one single tooth, you know, at 22. But 3 years. Our Guinness record is 1 year for a full arch in mouth. But sometimes we get breakage on the PMMA. Most of the times they are related to faults on the design, because they leave that special part very, I would say, thin. Not so big, you know.
Yeah, the connection parts are really thin.
Yeah, with a small connector, and but this is always for us in our workflow. This is always a warning sign. Okay, we need to, of course, remove the temporary prosthesis and make a perfect exploration of our implants to be sure that everything is correct and there is no failing implant on the arch, you know. And sometimes we find screw retain abutment, loose screw retain abutment, because sometimes when you are placing your screw retain abutment while in surgery, I think that I just place it with the right torque, you know, but there is some small amount of bone that can allow the screw retain abutment to be very stiff, very hard on the implant, and in the forthcoming months that bone disappear and the screw retain abutment comes a little bit loose. It's always a warning system. We are doing every day TeleoCAD temporaries, and I will say that only, it is difficult, to be honest, to give a number, you know, but I would say only a few. I would say only a few. That's the reason, because we are very confident to go to the final with most of those cases. And another one important question is that, for example, when we are going to the screw retain abutment, to the multi-unit abutment, we do not use metal T-base, you know, vario base. We go direct with the PMMA to the top of the screw retain abutment, because we are much more confident on the TeleoCAD direct to the screw retain abutment than the glue of the T-base to the PMMA. Sometimes it becomes loose. Maybe we are not doing in the correct way, you know. Yeah, I think we need to think twice. I'm talking about I2 regarding that protocol to how to glue in the correct way the T-bases, you know. But we have no time to do that. So the question is that we are very confident with that.
Okay. Before my next question, I would like to see you a bit more on your right side, because the camera can't.
Oh, sorry.
Yeah, perfect.
Sorry,
right now.
Sorry.
Just perfect right now. Okay. So you are using the digital technology and everything is fine, as you say. But what is the missing link? On your daily protocols. So which features or which technology will fulfill everything and complete all question marks?
Yeah. Let me think about what's the missing link. What's the future? I think that monolithic materials reliable monolithic materials, even printed materials, printed zirconia or materials like that, ceramics, will be a big advance. And now, I would say that the missing link now in digital is the correct information to dentists. Try to avoid misinformation. I will say only with that, because I'm talking also about me, because all of us, we are talking about our own experience, and technology is evolving much quicker than we are evolving. It's impossible to be up to date, you know. So for those dentists thinking to start with digital, I think we have to tell them, this is a new dentistry, this is the moment, and you have to look for the correct learning process. You have to select what you want to hear, you know. It's the same that in politics, you know. Yeah. You need to be very careful what you are hearing and have your own. So I think that regarding implantology, of course, in the market, the I2 device is mandatory to fulfill our treatments the way we are working, because other people is working in another way with success, you know. And I will say that also that the treatment has to be seen more than ever as a teamwork, you know, team working on that, with a high expertise with all the people involved in the treatment, especially with our friends, the dental technicians, which are amazing, you know. And I think those are very important, you know. The way to select the correct learning process, of course, to buy the correct products, that's very important. You know, I would say it's very important, because those are expensive, and I cannot see any other link, Sina. I would say that, you know, it's missing link, you know. Maybe you can suggest some missing link. What do you think?
I think the accuracy of, like, there are steps, like many steps, like having the correct CBE, having the correct intraoral scan, having everything. Like, there is too much data. So when you combine everything, and each of them gives you, like, let's say 15 microns of errors, that in the total you have like 150 microns, which is huge for a implantology level, let's say. So I feel like this accuracy problem will come as a solution afterwards, and then we will have less errors, and then we will have the solution maybe to place our implants, seeing the quality of the bone as well during the software, as we are doing it right now actually, and we might even have the possibility to place all the contemporary restorations without having the healing period, maybe, let's say. As I feel this will be the future, like in couple years maybe, I don't know, maybe shorter, but this will be the final ultimate goal of the all the market is aiming for.
Yeah, that's very important. Yeah, I think so. Yeah, also. Yeah. The reality of the hardware, of the material, you know. Yeah, that's very important.
This is like an industry, and it's not really, the industry is not really caring about people's, not the dentist's lives, not the patient's healthcare. They are just trying to make it easier and easier and faster and accurate, let's say. So that's why the industry is pushing us to use those technologies to just gain more money, let's say.
No, the question is that I think of course everybody wants to make more money.
Yeah.
You know, but the question is that no, I can only say that we are happy what we are doing. You know, thanks to technology, thanks to the workflows, we are always thinking on new ways of working, new designs, new things. You know, that's very important, and it makes you to feel happy with your patient. Yeah. You see a patient crying, you know. Last week we performed a very tough surgery with a patient with a Lefort, old Lefort 2, you know, with a mini blade. Well, very tough, and to provide that patient with a same-day temporary prosthesis with a big atrophy, with a simple surgery in-house, not in the hospital. And that's only thanks to the workflows and the digital,
Yeah.
So I think I would recommend everybody to jump carefully in this not new, but this new approach.
Then my final question, just you're advising everyone to jump into this digital workflow, and what's your advices for the new beginners for the digital workflow on implantology, like for the guided surgery and also the whole process to complete in-house, like or in clinics to work with digital implantology?
If you want to incorporate everything in clinic, it's a huge investment. I will say that regarding the intraoral scanner, the clinic has to think to look for a scanner that allow them to make ortho, natural dentition, digital smile design, implants, patient monitoring, everything, And once they start working with the intraoral scanner, they will not change. Of course, they will forget about the regular way of working, And then it comes you to start thinking about the in-house production or have your lab as a reference close by you to help you. So I would say that for those people thinking to jump in the digital workflow, I will say, first of all, I recommend you to jump because there is water on the swimming pool. There is no problem. You just to think what you need, select the correct learning, select the correct company, and think that your future will be much more profitable from the ethical, moral, and also economical point of view, which is very important. You are going to provide your patient with an excellent treatment in the correct way, and you are going to be really happy. So as soon as possible, I will recommend to select the correct company. First will be select the correct company to keep informed with the last advance. Select the correct learning process, courses, what you are doing, webinars, everything. Make your own opinion regarding what you need in your clinic to be sure that you need the intraoral scanner, and then jump as soon as possible. As soon as possible.
Perfect. I mean, this is not the future anymore, so this is today. That's why I'm doing this show actually for people who are experienced in this dentistry concept, but working with digital as well, and just want to have their experience here. I would like to really thank you for your time. It's been an hour for a talk. It was a really pleasure for me to have you here.
It will be a pleasure if I will be by your side in Turkey.
Yeah,
that would be amazing.
we are really. So I would be happy to host you here anytime you want, for sure.
Thank you so much for your kind invitation. It has been a pleasure to be with you, and you know where we are. You all know where we are. And thanks to all the people behind our computer for being there. And I deserve you the best from the health point of view. Is that those are really tough times, and I want to send you my best wishes of health, and also from the of course professional point of view, same. Be happy.
Yeah,
be digital. Be happy.
Yeah, be digital. Be happy.
Stay safe. Digital. Be happy.
Yeah, that's a good motto for everyone, I think. So please don't leave the Skype call. I will just finish the show, and then we just have a final word with you. Luis Cuadrado was with me today on this show, and I hope you enjoyed our talk. You will watch all the other interviews on my channel. So next week I will have my final show before the summer break. We will talk about 3D printed face masks, and for the filter masks. on top of it to make a better fit. So we will see you on next week, and keep you safe before the COVID and everyone else. See you on another day.